there, it's Lee, and I'm here today to talk about the nitrous oxide and to let you know that I've made a number of more in-depth how to use videos for the nursing staff and for the midwifery staff that I'm going to upload to a YouTube channel, and I will also upload this one. So this one's kind of more of an overview for the obstetrician or the family physician in terms of your responsibilities, in terms of what the nurses may be asking you, or what you may be asked for, if there's any kind of contraindication or concern. So what we've done on the unit is we've provided some cheat sheets. They're on plasticized paper, and they are basically the guidelines themselves, which are available in Policy Tech. It's called Nitrous Oxide Use in Family Birthing Center, and we've just taken them and we've printed them on the plastic paper, and I'm going to get a couple more sets so people can actually take them into the room when they're using the nitrous oxide with their patient, and they can refer to them. So basically, I would encourage everybody to have a read through, and I will post it again, these guidelines, because I know it's a bit big, but it's very, very procedural, and it's laid out sort of in terms of responsibilities of the different people and in terms of process, and the education piece is there, and the how to set it up and everything. And you're probably not going to be needing to know about the setup and things, but the one area in which I do want you to be sort of to highlight for you is around indications of use and contraindications. So I'm just going to go through that right now and then take you kind of through a little bit of how we've developed the process for using this and having it checked. So most indications for use will be labor analgesia. So usually during the first stage of labor. Some patients have used it during the second stage of labor. I've seen it in my practice, but not usually. It's very hard usually to keep breathing things in and pushing at the same time. But it's, again, that may be something that you assess, or with the nurse or the midwife, they assess to see if that's actually working. So primarily patients during the first stage of labor and patients waiting for an epidural. Now, because we only have 2 of these units on the floor, we probably don't want to use it for someone who's 3 centimeters dilated for hours and hours and hours. Unless that person has a total contraindication against for an epidural, and they do not want to have a PCA, they want to have something in labor, and then again you can make that decision. The nice thing about nitrous oxide is that it does have a very rapid onset of action, so usually within 30 to 45 seconds, and it also has a very short half-life, so there is no cumulative effect. So we can use it for longer periods of time if we need to, and we're not worried about the neonatal effect. Other procedures that may be good indications for use could be people who are having an external cephalic version. If there's people that do not have an epidural and they require a manual removal of a placenta, a vaginal laceration repair, if someone has a removal of a cervical suture, or insertion of a Foley balloon for cervical ripening. So this unit is completely portable and can move around, and it can go to triage, and it can be used successfully in triage. The most important piece is around the scavenging system. I'm going to go through that in a minute, that it's hooked up to the suction container. Now, the following might be exclusions for a patient who wants to use nitrous oxide gas. So in each situation, you need to have a thorough risk assessment and possibly a conversation between nurse and healthcare practitioner, or nurse and physician. Patients who've been given, or those who take opioids, benzodiazepines, and other CNS depressants. So of course we're worried about respiratory depression here. Patients with acute respiratory infections or respiratory disease, and patients who have undergone jaw surgeries or facial injuries which prevent them from obtaining a good seal with a face mask. So that is a key feature right now, and this actually is the face mask with the filter. I've just taken it off the unit because right now the unit is open and I don't want to breathe in the gas, but they have to maintain a really, really tight seal, which is really important. And actually maybe taking my glasses off probably would have been helpful for that. The next following 9 things will most likely exclude a patient from being eligible to use the nitrous oxide gas, and again, may require a conversation with the practitioner. So the first situation is a condition where there's a potential to create a space for the collection of gas. So this would be a patient who's had a recent pneumothorax, gastric bypass surgery, or an inner ear surgery, because with the inner ear, you can actually get a collection of gas which could cause a tympanic rupture. Documented pernicious anemia or vitamin B insufficiency, so that is related more to the ability to metabolize and excrete the gas. Increased intraocular pressure or previous eye surgery, except for LASIK eye surgery or other vision correction surgery. That is not contraindicated. Obviously, abnormal fetal heart rate tracing, any safety concerns regarding the patient ability to self-administer and hold the own face mask. So that is probably one of the most salient features of the need for education for the patient, is that they're holding their own face mask and somebody else isn't holding it for them. And then if they breathe too much and they get dopey, their hand is just gonna fall away, okay? Acute drug or alcohol intoxication, impaired consciousness, hemodynamic instability, and impaired oxygenation with either one or the both features of a respiratory rate less than 12 breaths per minute and or oxygen saturation rate less than 95% on room air. And this is prior to administration, okay? We're going to be setting up resuscitation equipment for both the birthing parent and the baby as part of our procedure, as well as continuous presence must be maintained by the RN or the RM while patient is using the nitrous oxide gas. Okay. We're going to educate the patient about the need to hold their own mask and about some of the side effects that they may encounter, like dizziness or dry mouth, possible nausea or vomiting. The patient needs to stay in bed the entire time. While they're not using the gas, they may be able to get up to go to the bathroom, and the nurse or the midwife can perform a falls risk assessment and see if that's appropriate, or whether they need to go on a commode chair or they need to go on a bedpan. They're going to teach them how to breathe during the contraction or the painful procedure, where it's going to be a number of rapid inhalations and exhalations into the mask to bring the level up so that they can achieve a maximal, I think it's a peak, maximal effect is achieved around 45 to 60 seconds. Okay, we're also going to perform vitals on the patients and obviously fetal health surveillance prior to use, and blood pressure, pulse, O2 saturation every 30 minutes. So it does not require continuous oxygen saturation unless the patient's status has changed, in which case vitals and any other kind of assessment will be done more frequently. Temperature should be checked every 1 to 2 hours. As I said, continuous pulse oximetry is not required. Continuous fetal monitoring is also not a requirement of nitrous oxide administration. And unless there was a need for fetal monitoring, prior to the nitrous oxide use, then they would have to be monitored continuously, and they would have to have a 20-minute tracing of normal category prior to the administration of the nitrous oxide, or they would have to have intermittent auscultation done if they're a candidate for intermittent auscultation, and that must be categorized as normal prior to the use. Otherwise, fetal health surveillance, Q15 minutes, as we do in labor. Falls risk assessment, and the other piece that's a bit different is a sedation score and a pain score. That's every 15 minutes. And sedation score is the normal sedation score that we use when patients are on PCA, narcotics. So it's 0 is none, 1 is mild, which is occasionally drowsy or easily aroused. 2 is moderate, which is frequently drowsy, easily aroused. 3 is severe, which is a somnolent patient or very difficult to arouse, where you maybe need to give a little sternal rub. And S is sleeping. Now, sometimes our patients do nod off when they're in labor, in between contractions, so we need to make sure that they're arousable when they're sleeping, so that we can differentiate that between a sedation score of 3 versus sleeping. And if they are, if they have a sedation score of 3 or a respiratory rate of 8 or less, this could lead to a respiratory arrest and possible cardiac arrest. So we're going to stop the nitrous oxide at that time and notify the healthcare provider. So if it's a midwife, they will notify the OB, and if it's a nurse, they'll notify the OB and or the family practitioner. Providing oxygen by mask at 8 liters per minute, taking vitals, probably at this time putting external fetal monitor on if the patient hasn't already been on the monitor, and being prepared to increase the oxygen to 100% at 10 to 15 liters per minute if the patient becomes unresponsive, checking for pulse and breathing, and if the patient is not improving or becomes pulseless, we're calling a code blue, a protected code blue, and being prepared to call an OBS alert and possible code pink as required. That is probably the worst case scenario. So I talked a little bit about common side effects being feelings of euphoria. Sometimes patients feel claustrophobic, where they don't really like the mask on their face, but what we don't want is breathing in and then blowing out into the environment. Dry mouth, perioral tingling, throat irritation, we can offer ice chips or sips of water. If they're drowsy or dizzy or disoriented, they can stop use for a bit and then reinstate use. Nausea and vomiting, if they can stop use for a while, and then when the feelings subside, they can reinstate the use if they like. And obviously if they vomit and this is all a mess, we can change it for a new one. Emergency situations, so this is where we would need to involve the obstetrician if we have a midwifery patient or an obstetrical patient and or possibly a family practice patient, but it is related to the earache, which is due to an increased pressure in the middle ear, which, as I said, could lead to a tympanic membrane rupture. So we're going to stop the use of the gas, and we're going to possibly need a referral to ENT. If our patient is experiencing any of the following: irregular breathing, involuntary eye movements, gagging, dilated pupils, rigid muscles, or prolonged inspirations, we are going to stop the inhalation and notify the OB and or the family practitioner. Okay, we're going to stop nitrous oxide gas otherwise when there is no longer a patient desire or need, when the epidural anesthesia is initiated, and when there is, obviously, if there's evidence of patient or fetal compromise. In the guidelines, there's lots of pictures with lots of the parts that are there. So I'm not going to go through those right now, as well as the procedure for setting up and taking down. So the last thing I want to do is I'm just going to switch this over, if I can. No, I can't. Just to, yeah, that's not going to work. Hang on. Now, I know this is going to look backwards for you. It's just the way the camera is working. I can't switch it midway. But this is what the nurses are going to be assessing. Clearly, I'm not very good at camera work, but there. The nurses are going to be assessing, when they turn the machine on, that the lines are all attached, and these lines do not need to be changed. We have 2 tanks on each of the units, so we can switch over if we run out of nitrous oxide or oxygen. They're going to be assessing line pressures and tank pressures rather, line pressures, and making sure that our blender, that these are all within the green zone before they're going to be using, and there's some troubleshooting for them if they need it. We also have a process in place with our respiratory attendant, who is here during, on weekdays only, between 8 and 1400 to, he's going to come 3 times a week. He's going to check all of our pressures, change tanks as required, provide more masks, filters, scavenging tubings, etc. So we've got that built in. As I said, we have 2 tanks of each nitrous oxide and oxygen on each unit, plus we have 2 tanks of nitrous oxide extra on our in FBC, as well as extra oxygen. So I don't think we'll be running out. We really want to try to avoid asking the RT for help because they are quite busy with their other duties. And I did do a video a while ago of how to change the tanks, and I may need to just refresh that. So if you have any concerns or questions, please let me know, but I hope that this was helpful, and I look forward to our patients using it. Thank you.